Hi, you guys. Welcome to Ask the Egg Whisperer. I'm so excited to have one of my closest friends, Dr. Ambartsumyan, on today's Ask the Egg Whisperer. And she's going to help us answer all of your questions today. She's from Reproductive Partners. She's in Los Angeles. And we went to UCLA together, and I've known her since I was like 3 years old. Well, it feels that way. I'm Assyrian, she's Armenian. It's kind of like we're the same people. People have a hard time saying her name. They have a hard time saying my name. You see, we're practically sisters. And we take care of patients in a lot of the same ways. We both just adore our patients. We're rooting for every single person that sees us. So before I bring her on, just wanted to let you guys know that today's show is sponsored by Proov. So Proov Test, Proov Test. You can go to proovtest.com, and they created a special code for us. All caps, Amy, AIMEE 25 for 25% off. And they'll just be putting in messages throughout the show today as we're talking so that you guys can learn a little bit more about Proov. So Proov has a test called Predict and Confirm, and it's a dual hormone kit that has 15 LH tests and 5 PDG tests that allow you to confirm ovulation. Okay, so let me bring up Diane. There she is. Here we go. Let's partay. Thursday, Egg Whisperer. It is a blast here. She's going to come up any second now. And you guys sent in so many great questions, so thank you. Hi, Diane.
Hi.
It's great to see you. Of course. Are you ready?
I am ready.
Okay, excellent. Let's do this. This question is from Brianna. Okay, so Brianna says, I'm a medical student, third year in Chicago. I'm 26. My husband's 31. We stopped using conception, I think she meant contraception, June of 2019. Not truly trying, but hoping at the same time. But since June of 2020, I started getting worried. Tracking BBT, cervical mucus, LH strips. I mean, that's a whole lot of tracking. Day 3 FSH is 10, AFC 19, AMH 2.94, day 21 progesterone 10.8. We're starting to get really discouraged. The last 4 months have been really tough with the time and mental energy it's taking out of our already busy lives. My husband is also a doctor. We are so excited to become parents and aren't sure if we should explore IVF at this time or what is the best route for our hopeful family. And thank you for being so wonderful and helping educate, uplift, and empower so many women. Diane, what would you do if you were 26, a third-year med student in Chicago?
Try to figure out a way to reduce stress. I mean, I would think, you know, a medical student and a physician husband sounds like they got a stressful life. And on top of it, like you said, she's doing all this extra testing, and which probably puts her, you know, a lot more stress. But I would start off with, I mean, sounds like, yeah, her FSH could be a little bit borderline, but age for me is the biggest predictor. She's 26, so her odds are great. But we all know that even in our 20s, our odds of monthly conception are not that high.
Right.
So I think I would just, you know, I'd be reassured with some of the numbers on her age, but I think she needs to start seeing a reproductive endocrinologist locally, so that they can look at all the factors. I missed that. Did her husband get tested? Semen analysis?
Yeah, so I don't see that we've done. So it looks like her levels have all been tested.
Right.
So she did the hormone stuff, and it sounds like she had the ultrasound. But we're missing the tube test. We're missing the sperm test, the carrier screen. So, you know, we have some parts of the tushy, but not the whole tushy.
Right. So that's sometimes a big, you know, a lot of times women start kind of looking at themselves, which is great, but we're forgetting the half the equation is sperm. So we got to get him in there and get him tested. And healthy for men doesn't necessarily mean that they're going to have, you know, normal sperm parameters. So, and IVF isn't necessarily the only treatment. I think that's another misconception that patients have. That
I agree.
The only treatment is IVF.
Do you guys do semen analysis at your lab? You probably do. Guys come in there. Yeah. So for me, I don't do formal semen analysis in my office. So I have patients do a test. It's called Meet Fellow. Have you heard of that? It's a home semen analysis kit you can have shipped to your house. And then they give a report 2 days later. It's really cool. So for guys who are super busy, it's a good way of doing that. You know. Okay, cool. So Brianna, don't worry. You've been trying since June. Your levels look good. You're 26. But just like Diane said, we're thinking about you. Your FSH is 10. You know, we shout at the top of our, I mean, not shout. We don't shout. But we educate people about freezing eggs. And I don't think we do a good enough job encouraging people to freeze embryos. Right?
Right. Especially, you know, being in medical school, maybe residency next, and who knows what else. So that's always a great option, especially in
Yeah,
her age group.
absolutely. And when you do OBGYN and then become a fertility fellow, that's another 7 years, right? 7 plus 26 is 33, you know? Okay. So now we have a question from Samra. What did you say?
And I said, who's counting?
Who's counting? No one's counting. Samra is saying this. Hi, doctors. I'm on my third IVF cycle. I'm 28 years old. My AMH is zero point 0.2. I've tried high dose Follistim 450, then 225 in Menopur, and I notice my lead follicle gets to 15 to 20 millimeters. It grows too fast, and the estrogen level stays at 300. I end up losing the lead and don't get many follicles due to my low AMH. Should I ask for a different approach? What would you do? And what do you think about low dose HCG? What would you do in a case like that? 20 years old, 28, AMH point 0.2. What do you think?
Well, again, like she's 28,
Right.
right? But unfortunately, for someone at 28, her AMH is low. So I think in cases like this, and I think you and I have talked about this on a different podcast, that I would go lesser is more type approach, because for her, she's young. She doesn't need to get 20 eggs or 10 eggs or 8 eggs even. She
Right.
may only be able to produce 1 or 2 or 3 eggs per cycle. So if that's all she's going to produce, I wouldn't necessarily put her on those high doses of medications. I would go very gentle. Sometimes either with just pills, Clomid, and sometimes with a little bit of injections. And I would try to potentially see if I could try to synchronize her follicles in a way where it's not suppressing her too much, so she doesn't get to that lead.
And how do you do that? What's your special suppressing sauce? What do you use?
Well, sometimes I'll use birth control pills, but sometimes, again, birth control pills can suppress women, especially with lower ovarian reserve, more. So mid-luteal estrogen priming is another secret sauce that I use that helps to hopefully synchronize them. I say hopefully because sometimes it's
Right.
really, really difficult to synchronize women like her.
Right.
So,
And then how much estrase do you use? I mean, I've seen some estrase priming protocols and they're in like 8 milligrams a day for like 3 weeks beforehand. How do you do your
no.
estrase priming?
I confirm that they've ovulated, and then within about a week of ovulation, I put them on estradiol about 2 milligrams twice a day.
Mm-hmm.
Sometimes, if they're really sensitive to it, I'll even lower the dose and just go to 2 milligrams once a day.
Got it.
And
And
in theory, it
yeah,
should be about a week or 7 to 10 days until they start their next period.
got it. And what's sensitive? Like, how do you know they're sensitive to it?
Sometimes they'll just have side effects.
Oh, got it. So like sensitive, like they're feeling more emotional, having
Right,
insomnia. Got it.
right.
Cool. So then she asked about low dose HCG. What do you think about that?
I'm not, I mean, low dose HCG is basically a lot of times people supplement if you're using pure FSH like Follistim or Gonal-F instead of Menopur. So if you want to supplement a little bit of LH, that's when low dose HCG is used. So I think that's definitely an option. But if she's going to use low dose HCG, then she'd also have to use a little bit of low dose gonadotropins, like not Menopur, obviously, but maybe either Gonal or Follistim. But I
Right.
don't really use low dose HCG as much.
Yeah, I don't either. I mean, I think in the old days when Menopur wasn't available,
Right.
doctors were using it, and a lot of the doctors that use it right now tend to be over the age of 60. I'm just kidding.
Mm-hmm.
There's nothing wrong with that.
No,
I've seen younger doctors use it too, but you just do what you're used to.
yeah, yeah.
So just to remind you guys, Prove Test has given us a discount code, all caps Amy, AIMEE 25. And in the kit that they sell, it's the Prove, Predict, and Confirm, has LH strips as well as PDG strips. One day I'll be able to say that. And by tracking both things, LH and PDG, you get the full picture on ovulation. And they're just going to be giving us ovulation tips and throughout today's show. So I'm glad they're here. Okay, so this question is from Ashley F. Doctors, I have excruciating pain every month. I finally told a doctor about it and figured out through surgery back in July that I have endometriosis. I was taking letrozole 2.5 milligrams for a while before surgery. After surgery, I didn't receive any positive ovulation tests, so my doctor upped my Femara dose to 5 milligrams. Even after surgery, I still have that pain. So I skipped taking meds this cycle because the doctor thinks it might be making my pain worse. I still tested with OPKs just to see, and I also checked my cervix position. My cervix was high and soft, but I didn't receive any positive OPKs. Does that mean I didn't ovulate? Could I have ovulated and just missed my positive? Also, what's your opinion on my pain that is still going on? What do you think, Diane?
Um, I'm still stuck a little bit on the letrozole 2.5 and then letrozole up to 5.
Yeah,
Um,
I'm thinking it was just being used for ovulation induction. At
oh,
first, I thought
okay.
maybe she was using it for like endometriosis treatment, but I think she was
Right.
using it for ovulation induction
Right.
for
Yeah.
fertility
Because I was
treatment.
gonna say if she's using it continuously, that could potentially be the reason as to why she's not getting an LH surge. Because she's
Right,
she's
right,
suppressing her surge.
exactly.
So that's one part of the question. If she's using for ovulation induction purposes, she should really just be using it for 5 days, not continuously. Or
Right,
some people will do 7, 8 days, but 5 days is the norm.
right.
Second part in terms of ovulation, it's just so hard to know unless you've actually followed someone through. So she could have still ovulated and missed
Hmm.
her OPK.
Hmm.
Um, that's a really difficult question to answer. I would recommend monitoring next cycle to see if she's truly ovulating or not. But,
Absolutely. And that's what you and I are here for.
right,
Clearly she's working with someone that's prescribing the letrozole or Femera. Get in for an ultrasound,
right,
and then if you don't have a doctor that, or you're so far away from a doctor, you can do the prove test. Just
right.
fit right in
Right.
there.
I mean, that's one of my pet peeves because a lot of times I think patients do disservice by taking the medications to take for the sake of taking them without any monitoring because even if things don't work, meaning you didn't get pregnant, it's still helpful information to see how you respond to the medications instead of just kind of
Exactly.
bumping up on the dose.
Exactly. I agree.
Yeah.
Okay. So next question, this is related to sperm. Okay. This is from Nicholas. I'm 36 years old with 2 semen analysis results. My first result had a 1% morphology, everything else normal. Second result, 2% morphology, rest normal, but rapid progression went down from 30 to 2%. My partner's 42. Her AMH was okay. HSG, okay. We tried for 2 months naturally, but haven't conceived yet. This is our third month, just ovulated last week. What do you think? Should we still continue to try naturally or should we consider IVF? What would you do?
I would get in and be seen by a reproductive endocrinologist, not because I'm so concerned about the 1% and 2%. I mean, I may be, but
Right,
because I'm constantly concerned about your partner's age, Nicholas. So even
right.
though it sounds like her AMH is good, she's got good number of follicles. She's still 42, which the good news is she's got a lot of follicles. So hopefully she'll be even a better candidate potentially for IVF. Low morphology overall doesn't predict inability to conceive, but it could mean that it would take you longer to get pregnant. And at age 42, unfortunately, we don't have that 6 months and a year to wait. So,
Right. I mean, each embryo has maybe like a 15% chance of being genetically normal. That means
correct.
85% of all embryos for a woman who's 42 will not be normal. And this isn't fear-based, this is fact-based. And
Mhm.
people just don't know enough about it. So both of you should take your CoQ10, go see one of us or someone that looks like us that's super supportive and excited about helping you, and join my Egg Whisperer school and take my IVF course and learn more about IVF there. Okay, so now we have a question from Finland. I'm 38 years old. This is from Sana. Single. I started IVF in August. My AMH is 0.55. My AFC is 5 to 7. In my first IVF cycle, I did estrogen priming, took some gonadotropins, and it was canceled because my follicles didn't grow. Second IVF was a mini IVF. First 5 days, I did letrozole, days 1 through 5, and then added Menopur 300 units for 6 days. And then we had 3 good-sized follicles, and we made it to the egg retrieval, and all had eggs inside. Fertilization was 100%, and they all made it to blast. And now we're waiting for PGS results, and in Finland, it takes 3 to 4 weeks. What do you think? Should I do another round to get more embryos just in case? I'm an ex-smoker and I worry that my eggs have a lot of chromosome issues because of that. And I've been taking CoQ10, melatonin, acai berry, NAC, and iron for 6 months. What would you do for a 38-year-old with that story?
Repeat what worked and not do what didn't. We don't, well, sounds like her second cycle was actually fairly successful. I don't know the results. We don't know the results of the chromosomal testing yet, but hopefully, given her age, at least one of those is chromosomally normal. So to answer the first question, of course, it's always better to have more embryos. The question is how many. A lot of times I'll discuss family with patients. It depends on how big of a family you want. And that's kind of always add one at least in terms of creating embryos. Other than that, I mean, if she did, I mean, 3 eggs, 3 blastocysts, that's amazing progression. So if it seems like she's found her secret sauce.
Right. Yeah. I mean, she won't regret doing another cycle. It's so hard to say. I just feel like if she's a solo mama by choice and she wants one baby, then having 3 embryos, and she might be all set. But either way, I don't think you can go wrong.
All 3 may be good. Who knows?
That's true. That is true. So let us know. Let us know. Please let us know. Okay. So this question is from Julie. Julie says, hi, doctors. Thank you for all you do. My doctor recommended an endometrial biopsy to test for endometriosis. Is this the same as the ERA test? Do you recommend having the biopsy first or proceeding directly with laparoscopy if endometriosis is suspected? Thank you so much for answering my questions.
So this is a different test from the ERA. ERA, I call it the timing test. ERA is endometrial receptivity assay to make sure once you're ready for an embryo transfer, to make sure the timing of the embryo transfer is personalized and appropriate for you specifically. The endometriosis test, it's performed at the same time, but it's a completely different test. The company that does it is Receptiva, where they look at an inflammatory marker for endometriosis, and then we send that sample separately. So I think we're missing some history points here, so I'm not quite sure where Julie is in her journey. But I would think I would definitely, you know, biopsy is an easier test than having surgery. Unless you know that you have endometriosis, which I may have missed. If you think you know you have endometriosis, then you don't really need to do the test. You can just go to laparoscopy.
Right. Yeah. I mean, I think that's the thing is sometimes people are told, well, it doesn't look like you have endometriosis, so why would you do the test? And the whole point is that's the point. You can't see it with your eyes, and silent endometriosis is so common. And we're seeing more and more studies about recurrent implantation issues. Notice I didn't say the word failure.
Right.
And sometimes treating people, I hate that word too. I hate unsuccessful. I hate failure. I like it didn't work.
Right.
And what did we learn? Yeah, I agree. Yeah, and then the other thing is you're right. You brought up a really good point is making sure you've already made your embryos before you start treating the endometriosis. In some cases, that makes sense too, especially if you're going to be given a medication like Depo-Lupron.
Right.
Okay, so you guys don't forget to use code all caps Amy, AIMEE, the number 25 to get 25% off the Predict and Confirm test. And they're chatting live with us during today's show, giving us fun facts about ovulation and how to predict it. Okay, next question, Guyan. This is from Grace. Hi, doctors. I've learned so much watching your videos. Thank you for taking the time to inform and help us. I just turned 40. I had 3 cycles of egg freezing this year, but the results are not what I expected. Here we go. AMH is 1.65, FSH is 7 at day 3. In my first cycle, I used 225 of FSH for 8 days, and I also used antagonist for 4. The results were 5 eggs retrieved, 2 mature, and nothing else viable. So she got 2 frozen first cycle. So now second cycle, she did 300 units of FSH, got 7 eggs retrieved, 4 mature, and the rest not viable. The protocol was the same for the last cycle, but the result was worse. 7 eggs retrieved, only 2 mature. Man. Okay, what would you do for someone who's 40, who's trying to freeze eggs, obviously like super motivated to do it because she's already done 3 and she's asking us about doing more? What would you do in a case like this?
Well, I'd have to look back at her actual stimulation protocol and see how big the follicles were when she was retrieved, and see if there is any room potentially to go 1 extra day to see if we can get potentially more mature eggs. It's just really, really difficult. This is why my egg freezing is the most amazing thing, but one of the biggest problems with egg freezing is we can't grade the eggs, so we don't really necessarily know the quality. I oftentimes find that maturity is also a factor of quality. So oftentimes, no matter what you do, sometimes that's going to be the percentage of mature eggs that a woman is going to get. That doesn't mean that the eggs are not okay, but I would consider perhaps pushing her 1 extra day. maybe sometimes I give double triggers to see
Mm-hmm.
if we can get perhaps a better maturity.
Mm-hmm.
Sometimes I will go a little bit longer after the trigger shot. Instead of 35 hours, maybe do 37, 38 hours to see
Mm-hmm.
if we can get that one or two more extra eggs. And don't forget vitamins, antioxidants, because I do think this could potentially be a quality issue. So whatever you can do from your end, I think that would help too.
Yeah, I agree. And we talked about doing a milder stim, maybe. I mean, if you're getting 2 to 3 mature eggs every
Yeah,
time, why take all the injections from the beginning? Maybe
right.
start with high dose letrozole. I know you use Clomid, something like that,
Yeah,
to get the eggs to grow in that way. And maybe you'll get more
yeah.
mature eggs. I've certainly seen that. I'm sure you have too.
I've had some luck with using Clomid and lower dose medications and going with a couple from like less mature eggs to more mature eggs.
Right,
So
right. I
it's a
agree.
trial and error,
I
unfortunately.
know, I know. It's the hardest part of what we do.
Yeah.
Okay, this cycle is from Jerry, 33 years old, going into the first round of IVF. Called clinic day one. It was a light period. Used a menstrual cup, 24 cc's in it. On day two, expecting more flow, which is normally 70 cc's, but it looks like periods had stopped. Questions are, have you ever seen this happen? My period's normally 3 days. What does that mean as far as starting my IVF cycle? The nurse said it's fine and just to start birth control pills is planned the evening of day two. What are your thoughts on why this is happening and how can it affect my IVF cycle? Thank you so much.
Sorry, I missed the question because people are saying that my mic is going on and off. So
Okay.
um, I'm gonna maybe let you take that question, Amy.
Okay.
I was distracted with the mic.
Oh, that's okay. So basically the question is when your period starts and you don't have full flow, what does that mean and does it affect your IVF cycle? So sometimes what happens is when you have a previous ovulation and that juicy ovulation, think of it that way, is still making hormones like estrogen, that can prevent you from having a really nice full flow. So if you start a birth control pill, I mean that's not a big deal if your clinic wants you to do a birth control pill start. However, that cyst could potentially still be there when you go in for your baseline ultrasound. So just be aware of that. So basically, it shouldn't affect your IVF cycle if the cyst is gone by the time you go in for your baseline, but realize it might still be there. It might still be secreting estrogen. And there's really, that's a good thing that you're asking so you can find out more about your body. I typically don't use a lot of birth control pills in my practice. And lately, I've been bringing everyone in for like a pre-IVF ultrasound before their IVF baseline, just because with COVID and everything that's going on, I feel like I need to be seeing people actually even more before their IVF cycle rather than over the phone because I wish I could just take a wand and be like, plug it in your phone, put it in your vagina. I can now see it on my phone. Wouldn't that be nice?
That'd be amazing. To
Okay.
follow up with what you said, we don't know her history. Sometimes that tends to happen even more if someone's been on Clomid or letrozole, any kind of like oral stimulating agent the cycle before. They tend to have leftover follicles from the prior cycle, which doesn't let the period come all the way.
Exactly. Exactly. Okay. So this question, Diane, is your headset working? Because I feel like I
I'm
don't
gonna
know that it
I'm
is.
gonna maybe take it off. I'm gonna take it off and see. Hold
Oh,
on.
that's better. Whatever you just did is the best.
I took it off.
Perfect. I can hear you now.
You can hear me? Okay. Great.
Outstanding. Yep. Okay. Problem solved. Thank you, everybody. Okay. So this question is from Ashley. I recently had my first appointment with a doctor in South Carolina. My AMH is 0.136, FSH is 18.6, estradiol is 44. He did an ultrasound and counted 4 eggs, and everything else looked perfect. He immediately said IVF would be a waste of money, and the likelihood of me getting pregnant at my age of 38 was 5%. He suggested donor eggs. Do you agree?
No. Well, I mean, of course, donor egg is an easier approach, and it's going to give her higher probability of pregnancy. But given her age, you said 38, right? Yeah.
38. Yeah, she's
Given
38.
her age, I think yes, she has lesser egg count. It's kind of like goes back to the one of the earlier questions we talked about. She was 28, but um, I would definitely still, I mean, I would counsel her appropriately that her
Mhm.
chances are probably not as high as the chance of the average 38-year-old who walks in and has AMH of over 1 and normal FSH. But I think she still has a pretty good shot because she's 38. So
Mhm.
at the very least, we got to try.
I agree. I mean, I feel
Yeah.
like she's so young, and when she's 45, she might look back and be like, why didn't
Right.
I try? But, anyone over the age of 35 will have a higher chance using an egg donor. I mean,
Absolutely.
it's like anybody. But Ashley, take your CoQ10, don't give up, find a doctor that believes in you. And I get it, like they're just trying to be
Hmm.
transparent
Hmm.
and give you a version of hope that I try and give people too, and I know Diane does, which is have only pragmatic and positive expectations. So they're just
Hmm.
being practical.
Hmm.
And what would you quote, like a 38-year-old blastocyst? Like, what do you think the rate of normality should be?
At 38, one
Hmm.
in three.
Yeah, I
Yeah.
agree. Yeah, so it's like
Maybe
it should,
better. One in three.
yeah. So even though her FSH is 19, she still has a chance.
Yeah.
Okay, so this next question is from Miriam. Thank you for supporting us in this journey of life. I'm 41 living in Germany. I've been pregnant naturally, and we are trying now for the last 2 years for my next baby. My first baby I had at 37. My AMH is 1.25, FSH is 5. I have 2 centimeter chocolate cysts. And in the last 2 years, they have not changed at all in size. I've been having them monitored very, very closely. So here's a story about my tubes. My left tube is almost closed. My right tube has prompt fill, and they're not so sure about spill. I've done one IVF in August of 2020. From the right ovary, I got 5 eggs. From the left, just 1 egg. All in all, 4 eggs fertilized, and I had 2 early blasts and 2 arrested. With the 2 blasts that I transferred, I got pregnant, but I had a biochemical pregnancy. I'm going to have IVF again in November. What do you think my problem is? Why did I have an implantation issue? What do you think?
Well, age obviously is one of the biggest concern in everyone. And
Mm-hmm.
at 41, we were just talking about odds of a normal blastocyst in a 38-year-old. We mentioned one in three. At 41, you're probably looking at best one in four, one in five,
Right,
right? So
right.
the obvious answer is, well, we haven't had the number needed to potentially have a normal blastocyst for transfer.
Mm-hmm.
So now that doesn't mean I would completely dismiss other issues and the endometriosis and implantation failures, but I think if I'm trying to pick what's the most common reason as to why it could have failed, it would be that we just didn't transfer the right embryos. And it's again nature's way of trying to give us a healthy pregnancy and a viable pregnancy and a healthy baby. Um,
Damn it, nature.
I know.
Why couldn't we
Nature
be
is so
made
bad to
more?
us. I
Why
know.
can't we be more efficient? And yeah, that endometriosis is toxic, especially if you
Mm-hmm.
have the tube situation that you have. Really talk to your doctor about maybe doing more cycles, freezing embryos, and then do a laparoscopy to remove the tubes, remove the endometriosis to pave the way for maybe an improvement in your implantation rate, don't you think?
Or suppression. Yeah.
Right, right.
I would
Yeah.
consider PGS in this case. I don't know how much they do that in Germany or in
Mm-hmm.
Europe overall, but in cases like this, because again, you don't know what the embryo quality is, PGS is a great option where you get the
Mm-hmm.
embryo, you test it, make sure it's normal, then you address the endometriosis, either like you said, laparoscopy or loop run for a couple of months, and then go on and do the transfer, hoping that you address the toxicity of the endometriosis, and now that embryo is going to stick.
Yeah, I agree. Okay, so Gayan, do you have more time with us? Can
I
you spend
do.
more time? Okay,
Yeah,
awesome. So what I'd like
absolutely.
to do is go through all the chatted questions because we have a whole bunch. Before
Great.
I do that, I just want to remind everyone that the Prove, Predict, and Confirm test is a test that can check LH to predict peak fertility so you know the best time to try. And then by testing PDG cycle day 7, 8, 9, and 10, past your peak fertility can confirm if you've had a successful ovulation. And use code all caps AIMEE25 for the discount code that they're giving us today. And they've paid Diane and I nothing to say this today. Zero.
Nothing.
Nothing.
But that's okay.
Okay. We don't want anything. We just love talking about stuff
That's right.
and about stuff that we believe in. Okay. So let's do this. Here we go. Would you allow women to get their hair done while preparing for an FET?
I do.
Yeah.
Because I think to feel good, you got to look good. So
I agree. I mean, you got to sparkle on the outside.
yeah,
If the inside's not sparkling so much,
I
and then
tell them just get it
eventually the
all out.
inside will sparkle.
Yeah,
Yeah, I
get it all
agree.
out of your system before your transfer. So
Exactly. Okay,
yeah.
next question is, what are your recommendations for at-home ovulation tracking for women with PCOS?
PCOS is a hard one because I mean it's all of the ovulation tracking methods should still work with PCOS, although with PCOS you get a lot of false positives. So it really just depends on the timing. right?
Right.
So if you have a long cycle, I have patients who come in and say, my cycles are every 60 days, but I have a positive surge on day 10. Then I
Right.
know it's a false positive. So PCOS is a challenge.
I agree. I
Yeah.
agree. I think I hate the term too, because people are like, "Oh, I had cysts. I had a big one." I'm like, "That's
It's
not what
no sis.
PCOS is.
I
It has to
know.
do with hope." God, I
Yeah.
keep saying hope. I created, have you heard of my hope mnemonic for PCOS?
Yeah.
High androgens, lots of follicles on your ovaries, periods that are regular, and eating and exercise. So all the things you have to think about if you have PCOS. And you don't just think about it when you're ready to have a baby because it's a lifelong
Hmm.
thing, right? Okay, so this is a great question. I'm curious to see how you would tell a patient what to do with this. What is the best way to convince an OB/GYN to do an ultrasound to check for fibroids and adenomyosis before starting to try for a baby? I keep being told, and I know that I have both, to just keep trying or start trying. What would you do?
Um, it's a hard one. A lot of OBGYNs in our area will actually do it. They will, if someone goes in and says, or if you have complaints, if can you think of complaints?
Right,
We know fibroids don't cause pain, but they can cause pressure, so they can cause pressure type symptoms. Adenomyosis can cause pain with periods or heavy bleeding. So I think I would think of symptoms and talk to them about symptoms.
right. I
And
agree. Yeah, I mean, I can't imagine telling a man no. It's like, oh,
yeah,
you got a big tumor in your tummy that's gonna
but
cause you all these issues
yeah,
maybe in pregnancy, and no, we're not gonna check it for you. Like, no, no.
yeah.
Okay.
If not,
Uh,
see your local fertility specialist. They'll do an ultrasound.
exactly. Okay, here's another question. Dear doctors, after one egg retrieval, how long is it better to wait for a second egg retrieval to get the good quality eggs? What do you do, Diane?
Depends on how many eggs they got. If someone's going doing mini cycles, which means they have lower egg count and they don't have that much time to wait, then I will go back to back. For someone who's had like a bigger retrieval, more eggs, I do like to take a month off in between. As far as I know, and Amy, you can weigh in on this. I don't think there's any data, and I get asked this question all the time. What's better for quality? And I say it's all about numbers.
Right.
So to me, if the ovary is recovered, there's no residual cysts, then you can move on. But generally, if you had a lot of eggs retrieved, there's going to be some residuals the next cycle. So we just
Right.
wait.
Right. I agree. Okay, here's a question. Hi, ladies. I had my first 6-week ultrasound today and everything is measuring right. However, the doctor noticed that there's internal bleeding, and I imagine she's talking about a subchorionic
Hmm.
hematoma. Her question for us is, should I be worried?
So subchorionic hematomas are very common.
Hmm.
I would say I see it at least in at least half the pregnancy, if not if,
Yeah.
if not more. So I mean, I would be careful, and that's just the voodoo medicine in me, just
Right.
trying to. There's no data saying that being on bed rest or this and that's going to help, but other than that, I would just take it easy, try not to stress about it, and
Hmm.
not worry too much.
Yeah, I agree. I tell patients 40, at least 40%.
Yeah,
And then people ask me, but like, why does it happen? And I'm like, I know this sounds like a smart aleck answer, but it's because you're pregnant.
yeah,
I mean,
yeah.
that sounds snarky, but
And I
okay.
think we're
Yeah.
seeing them because we're following them. A lot of
Hmm.
the patients, a lot of the women who get pregnant on their own, they don't even see their OBGYNs until 9, 10, 11 weeks. So,
Exactly.
of course, they've had the subchorionic. It's just not seen anymore at that
Right.
stage. So,
Right. Okay. I'm 29 years old. All tests are normal. I'm starting my retrieval cycle today, but having a chemical pregnancy, does IVF decrease the risk of miscarriage? So I think what she's saying is she's had a biochemical in the
I see.
past. Will IVF help with that?
Uh, what was her age? 20,
29.
29.
Yeah.
Well, IVF helps with creating more embryos, but if you did chromosomal analysis on the embryos, then that would, in theory, reduce the risk of miscarriages.
Hmm.
Although at 29, if you look at I mean, her history sounds like she may have had miscarriages, so she'd be at a higher risk. But overall, even with IVF, PGS tested embryos, unfortunately, there's still about 10-15% risk of miscarriage.
Hmm.
Um, so depending on the age group, that difference with testing versus no testing is bigger. But
And
the
that's
short
still,
answer is yes.
yeah. I mean, it's still hard to understand why these embryos
Yeah,
still miscarry for people who aren't in
right.
who do what we do. I mean, for us, it's like we know that chromosomes aren't everything, and we
Hmm.
know that the technology that we use has like a certain resolution, and anything that's smaller than what we can detect could results in an embryo that doesn't work. And God, I wish we were better than we were. You guys are doing non-invasive. Are you guys doing non-invasive PGS yet?
We're not. Are you?
No, I
No.
wish. I would love to. Do you
Yeah.
see it as a way, something that we'll be doing in the future?
I hope so. I think it's a little bit challenging because for non-invasive, you have so for everyone listening, usually when we grow the embryos in the laboratory, they're grown in bunches. So it's not
Hmm.
one embryo at a time. So it's a little bit more challenging for the embryologist to grow one embryo at a time in little chambers. Plus, we also don't know. Some people think embryos need each other to grow better. So they keep
Oh.
each other cozy. So but I do see that the way of the future, hopefully.
Yeah. Okay, great.
Yeah.
Okay, mito scores. What do you think about mito scores? So this patient, this woman, or this someone following us and watching us right now is saying that I have two embryos that are normal. The mito scores are 21.8 and 26.5. What do you think?
Um, I still haven't seen convincing evidence on MIDAS score, so I'll always tell my patients I use that as a tiebreaker if I
Right.
have. But I've seen people get pregnant with MIDAS scores of 30s,
Yeah.
and I've seen patients not get pregnant with MIDAS scores of 17.
Yeah.
So I put more emphasis on the actual quality of the embryo versus the
Hmm.
MIDAS score.
Okay. Here's a question. I had my day 5 FET yesterday. Is there anything you recommend I do or avoid that would help? Is it safe to have a pedicure, do my nails, get my hair done? Any fruits to avoid? What do you think, Diane?
Anything that's going to help you feel good.
Yeah.
It's all about stress and feel good. So I mean, we tell
Yeah.
patients to take it easy for 2 days, like house arrest, not really bed rest. But that's just that's just to help them feel better. But everyone is on house arrest now with COVID, so it's
Right.
it's easier.
Right. So I started a new website, Diane. I know that you know
Yeah,
about me and all the websites, and the
yeah.
website that I have is called um, IVFcabanaboy.com or IVFcabanagirl.com, where you can rent a cabana boy for 2 days. Did you know that?
No,
I,
I'm writing it down.
okay. Let's see here. In New York, let's see here. I'm just trying to look here for the next question. Oh, is it helpful to continue CoQ10 after the frozen embryo transfer and throughout the pregnancy? What do you tell your patients?
I tell them to continue until the pregnancy test, and then
Hmm.
I have them stop. But honestly, I don't have any basis for it.
Yeah, I mean, I
Pretty
tell them to
easy.
continue if they, let's say, have a
Yeah,
history of miscarriage. And
yeah,
I think that maybe even continuing could potentially help a quality. Like sometimes I help
yeah.
someone get pregnant, they're 38, and I want to do an IVF cycle as soon as they deliver. I say,
Right.
just call me from labor and delivery. I'll come over and I'll, check your follicle count. Just kidding. I don't do
She
that.
does that, by the way.
I wish. Okay, let's see here. Oh, this is a good question about the immunology workup. When do you recommend doing an immunology workup?
Immunology is a tough one because I do definitely think there are immune issues that can cause implantation failures and pregnancy losses. It's just that we don't have a really good way of measuring them, right?
Hmm.
So because a lot of times, yes, we check your blood test, but what we check in the blood is not necessarily consistent with what's in the actual uterus, right? People talk about
Hmm.
the natural killer cell assays and whatnot. Generally, if someone said miscarriages, then I would check the panel, or if we've tried everything and then we just keep having recurrent implantation failures, then I would go down that path.
Yeah. Okay, next question. Hi, I recently had an egg retrieval. I got 40 eggs retrieved. So far,
Oh,
19 fertilized. I'm 35, almost 36 with PCOS. My question is, should we do PGS testing? Cost is an issue.
30, did you say 35?
35, almost
Yeah.
36 with 19 fertilized eggs.
I think it's helpful to, especially for high numbers, to select down to the right embryo, but it's not necessary. One way I talk to patients about it is, look, if yes, cost is definitely an issue, but if it's going to help you do one less transfer, then it kind of
Pay for itself.
pays for itself.
Yeah,
Yeah.
yeah, I agree. Okay, and here's a question about the HSG. If my HSG was good, would you still recommend a saline sono? How long are these tests good for?
HSG is a great test for the tubes and the shape of the uterus, but it's not the best test for like polyps and things like that. So it really depends on what you're doing. If someone's doing a transfer, then I still like the saline sonogram to make sure I'm not missing anything subtle, or sometimes I'll do diagnostic hysteroscopies.
Hmm.
Um, for someone who's just trying to conceive and doing IUIs and whatnot, I'm satisfied with just the HSG. But I
Hmm.
also pay attention, and especially in the follicular phase, you can actually get a lot of information from just looking with an ultrasound.
Right. And sometimes with the implantation testing that you and I do, I will do, like you said, the hysteroscopy at the
Yeah.
same time
Mm-hmm.
and do a saline sonogram sometimes too. I feel comfortable doing that.
Mm-hmm.
Okay. How do you feel about a mini IVF cycle after a first IVF cycle that did not work?
It depends on the how many eggs one retrieved and all the other criteria. So it's hard to answer that question without more details.
Yeah. I mean, I would say if your doctor thinks a mini IVF would help you, I feel
Yeah,
like that's a great idea.
right.
Okay. So NAD, do you take NAD, Guyan?
I don't, I need it, but I'm recommending it for everyone. That's why you look so great.
I'm 75. Can you tell?
You're not 75.
I know I'm not. I need to check my FSH estradiol
If you're
AMH
75,
today.
it means I'm 75 and I'm
That's
not.
true. I know. I know. I take NAD. I think it puts a little a spark in my step. And
But
I'm
I'm
track I'm
definitely recommending it to a lot of the patients
yeah.
now.
I'm tracking. I need to check my FSH estradiol AMH today. Today was the day I was going to
Mm.
do it. I've been tracking it over time to just see if it's going to help and prevent me from going into menopause. Wouldn't that be cool?
NAD, that's interesting.
Yeah, I mean, if it's supposed to help with egg quality, don't you think it should also slow the progression of ovarian aging?
That'd be amazing.
Yeah, we'll see. I'll publish the study in 10 years.
When
Um,
you're 85.
when I'm 85, exactly. Okay, here's a question about DHEA. Do you recommend DHEA testing and supplementation?
I recommend supplementation. I don't necessarily recommend testing because you can't even measure DHEA in your blood. You have to measure DHEAS, which is the
Hmm.
more stable form. So I generally just give it for women over the age of 38, or if they have diminished ovarian reserve.
Yeah, I mean,
And if they
sometimes
start complaining a lot of acne
a
and
beard,
oily
a
skin, a
mustache.
beard, or start talking with a
All I
deep
do.
voice, then
I do the
no,
same
it's a
thing.
yeah.
I've seen that. I had a
Mm,
patient come in and I was like, "Oh God, you have to stop the DHEA."
yeah.
Have you had someone come in with a deep voice?
Yeah, or some, well, not really for deep voice, but they all of a sudden start complaining, and they're like, "Well, I've been on the HEA for a long time. Why am I getting this all of a sudden?" And I'll say, "Well, did you get a different formulation?" And they'll usually say yes. So that's
Hmm.
the thing with DHEA, because it's not controlled by the FDA. Depending on where you buy it from, you can actually get very different amounts of androgens.
Right.
So sometimes, depending on how high that level is in that formulation, you can
Hmm.
definitely have symptoms.
Hmm. There's a question here, and I'm trying to make sure I understand it, so bear with me. We're scheduled for a new diagnostic workup. If all looks good, would you recommend going straight into STEM on the next period, or should we wait in between for a month? What would you do? Diagnostic workup, wait a month IVF, or diagnostic workup IVF?
Diagnostic workup IVF. There's really no reason
Yeah,
to wait.
yeah. Unless there are
Yeah,
things that you can do to give yourself a better chance, like eating
right.
better, exercising every day, reducing stress, stuff
Vitamins.
like that. Yeah. Okay,
Yeah.
cool. Are there any other ways of checking progesterone besides a blood test?
We don't do it, but I know there is. Do you do it? The
No, I mean,
progesterone? The
there's the PVG.
right.
I mean, I know that question wasn't planted, but
Yeah.
to have us talk
Right.
about the proof test, but
Right.
that's one way of kind of tracking your progesterone. And the other thing would be it can help potentially if someone has a problem with miscarriages to make sure that they're getting progesterone that they need.
Mhm.
Here's another question. I'm 45, doing a transfer in December. I have one healthy embryo. Wow, that's
That's
amazing.
amazing.
Holy smokes.
Yeah.
I want to know what you did to get that embryo. Let
Hmm.
us know.
She took NAD.
Probably. What are my percentage chances that this will be successful?
Well, it's very clinic dependent. I think success rates, but usually once if you have a chromosomally normal embryo, then age is no longer a factor.
Hmm.
So it should be the same chance as the 35-year-old who's transferring a chromosomally normal embryo.
Yeah.
So
And I would just study the heck out of your uterus. Do
yeah.
all the testing you possibly can. And I do something that maybe not everyone does, and I bet you do, Diane. I always have that heart to heart with like, what would you do if this didn't work? And maybe we should do
Hmm.
it up front. And
Hmm.
sometimes that's like use a gestational carrier, like use someone who's been
Yeah.
pregnant before that you know has had implantation. and has even maybe been a surrogate. Because I feel like having that conversation, like if a transfer didn't work, and then say like, well, maybe you would have had a higher chance with a surrogate, like that's not fair, especially when people have worked really hard to have a pregnancy with
Mm-hmm.
their own eggs.
Mm-hmm.
Okay, here's a question about the difference between gonal and menopause. They're both FSH, but what's the difference?
HCG, the LH factor.
Yeah.
So
Dun-dun-dun. There should be a
yeah.
joke there. No joke. Okay. How long should you take CoQ10 prior to an egg retrieval if you're freezing eggs for the first time? What do you tell your egg freezers?
Well, ideally, we always talk about the 3 months period. So I would say if there's no rush, 3 months. But sometimes it's a fine balance between scheduling and life and this and that. So I say, you know, longer the better. But
Yeah.
ideally, if you can take at least 3 months, that'd be great.
I think everyone should be given CoQ10 out of
Mhm.
college or by the time they're 25. It should just be like, here's your birth control pill prescription and here's your CoQ10.
With
They
your
should go together.
CoQ10.
Yeah, you should have CoQ10 compounded like in your birth control pill.
That's smart.
No one listens to my ideas, Gayan. No one. Okay, I have stage 3 endometriosis, cycle 1 canceled with poor response, cycle 2 got 7 eggs retrieved, waiting to see how many grow to blast. Thoughts on omnitrope for a next cycle? So I guess the question is, do you use omnitrope? Do you use it for endometriosis patients? What do you do?
I don't use it specifically for endometriosis patient, but I use it. I use it for egg quality. So for women over 38 or definitely over 40,
Mm-hmm.
or for women who have lower egg reserve, because if they have lower egg reserve, probably the quality is not as great as well. Or sometimes if they don't do well with the first cycle, then that would be something that I would add in the second cycle. So.
Okay, so here's a question about the difference between PGTA and PGD. What's the difference?
One is screening for chromosomes.
Mm-hmm.
So to make sure all the chromosomes are balanced, as we all have balanced set of 23 pairs of chromosomes.
Mm-hmm.
And the PGD is, or for PGT, I can't even remember the names right now, but that's for single gene. So
Yeah.
if you and your partner are carriers for one specific genetic disorder, then you can actually check for that, like cystic fibrosis, spinal
Right.
muscular atrophy,
Right.
things like that.
PGTM. You got the A, you got the M, you got the
MM,
SR.
yeah.
They're just trying to
SR,
like,
that's right.
yeah, they're
That's
trying
the
to make us
translocation.
into like rap stars. We got Dramey over here. What do you call yourself? I call myself Dramey. People call you
Sure.
Dr. A,
Dr.
right?
A.
Dr.
That's my rapper name.
Dre. I'm Dramey and you're Dre. Okay. Which DHEA do you recommend? I have my brand. What's your brand?
I don't have a brand.
No, I
I
have
want
a
to know your
brand
brand.
and I have a code. Are you ready for my code? I still
Yeah.
my code. I don't know how I remember them all. It's very easy, actually. So it's Theralogics. They have a micronized DHEA, and the
Oh, okay.
code is all caps in the word Tushy, T-U-S-H-Y. So that's the brand that shouldn't make you talk like a man.
Great.
Here we go. I did ERA testing, and timing was off by 1 day. Second round, I got 3 blasts. Tested this time, 1 normal, 2 mosaic. Transferred the normal and had a chemical pregnancy. I'm sorry. The rest of this question is this. I don't know what to do. My doctor suggests a 3rd round, but I'm scared it may not work. I'm desperate to give my son a sibling. Appreciate your advice. What would you do?
Sounds like you produce a chromosomally normal embryo, so I would definitely try it again. I would also look into those mosaics and see what the actual chromosomal abnormality is. I will consider transferring mosaic embryos again with proper counseling and depending on the abnormality, as long as the alternative is not live birth with issues, then that would be another discussion that you may want to have with your doctor.
Yeah, I agree. I tell people don't assume your mosaics are abnormal.
Yeah,
My approach is assume they're normal
right,
and don't discard
right,
them. And
yeah,
I don't know that the chromosome abnormality really matters. I mean, I think a mosaic 21 is going to be different than like a
right,
mosaic, 9.
right.
But I think the live birth rate could be at least 50% for these mosaic
Hmm.
embryos.
Oh, for sure.
Okay. So someone is asking, can we take NAD throughout pregnancy? And I say no. I say stop the NAD at transfer time.
Yeah.
Okay, chronic yeast infections, preparing for FET. I'm freaking out in case I get it during that time. Would you suggest I get on yeast medication now? What would you do?
Yes. But this is the reason we went into fertility, right? So we don't have to deal with chronic yeast infections. But
I'm like, yeast? What's that?
I would
I don't know what
definitely
that.
try to get treated.
Yeah,
before the
avoid,
pregnancy. Yeah.
absolutely, and avoid antibiotics. And the estrase gives you that egg white cervical mucus, and
Hmm.
like it just makes you more
Yeah.
prone to yeast infections. Absolutely treat it.
Yeah.
Okay. Let's see here. Chance of success about to transfer via an FET on round 3 of IVF. Last 2 cycles were not successful. This round had 3 embryos blast. One could be tested, and the 2 others were not strong enough. It's hard to know. I don't know your age. How much CoQ10 do you recommend, Diane, and dosing?
Um, Higher the better, right? Well, not too high.
Yeah.
What is your recommended dose?
Um, 360 milligrams. If you
Yeah.
use the Theralogics brand, 125 of that is equivalent to about 700 milligrams. It's compounded with something called Vesisorb, which makes it absorbed at a much higher rate than the other products out there. So that's what I recommend. And sometimes I recommend even higher doses of
Yeah.
CoQ10. I have patients take 2 tablets. I don't really go up to 3 tablets a day.
Yeah.
Okay, when do you recommend mini IVF over normal IVF?
For me, and everyone is different. For me, it really has to do with initially on a first try based on egg numbers. If I don't think I can get good number of eggs, then I would just jump straight to mini IVF or mild IVF.
Mm-hmm.
That's one criteria. Second criteria is if someone did regular IVF and didn't do well at lesser eggs or lesser quality eggs, then we do it.
Mm-hmm.
I do it for like quality purposes. Yeah.
Ooh, I like that. Mild IVF. Because
Hmm.
when I say mini, I feel like people think I'm just going to not try and get many eggs. But when I do mini,
Yes.
I'm still trying to
Yes.
get every single egg that I can possibly get.
Yeah.
Mild sounds a little bit like it's mild, but I'm still like
Yeah.
doing IVF. Mini
But
sounds like,
people still question. Sometimes I'll say, it's easier financially because lesser
right.
drugs, and it's easier uh, for quality. And then they'll still say, but put that finances aside. Oftentimes, patients feel like when you're doing gentler stimulation, you're actually doing them disservice.
Hmm.
But more often than not, I want to publish our data because women just do so much better with less meds.
I agree. Like I see these patients, they have like 5 or less follicles and they're taking like 450 units a day of
Crazy.
meds. And I'm
Yeah.
like,
Yeah.
no. Okay, someone is asking this question. Oh, back to that other question. She pointed out that she's 37 years old. So, chance of success, she's doing an FET, had 3 embryos. Basically, long story short, she has 1 embryo. It doesn't sound like
Mhm.
it's tested. What would you quote someone with a blastocyst? And let's just call it a good quality blastocyst at 37, just 1. And she gave us the background of her cycle.
About 30-35%.
Yeah, I agree. Okay, another question. I'm 42 IVF cycles, 4 total normal PGS embryos. First FET did an implant, second FET had a miscarriage at 6 weeks. I have
Mm.
adenomyosis. I still have 2 embryos. Do you recommend an immunology workup?
I would recommend assessing the adenomyosis, and if with adenomyosis, I definitely consider going on Lupron suppression for a couple of months,
Mm-hmm.
maybe combination of Lupron or letrozole or both, to before the next transfer.
And do a third IVF cycle. Do it
Hmm.
now. Get more embryos, and then talk to your doctor about the real deal, full transparency. What are my chances with my adenomyosis? Because adenomyosis is really not good for us when it comes to
Mm-mm.
implantation, especially if it's
Yeah.
moderate to severe. I hate adenomyosis. I need a shirt that says that. I hate adenomyosis. I hate endometriosis. Okay. So another question about NAD or NAC, which is best? I'll answer that. They're different.
Yeah.
NAD is NAD. NAC is
Yeah.
NAC. NAC,
Right.
I use it for like metabolic issues. Endometriosis. NAD is like egg quality stuff. Okay. Brand for CoQ10. Do you have a favorite brand, Guyan?
I don't.
No? So
You're
Theralogics,
the same one,
Thera,
right?
same one, Theralogics, and their brand is Neo, Neo, the letter Q, the number 10. I have to tell you a cock joke. Can I tell you a cock joke, Diane?
Go
This is
for
a
it.
true story. I had a patient. She came to me and she goes, she was really cute. She's like, Dr. Amy, because I email patients and I had emailed her the supplements and the supplement was COQ10. And she said, I went to the pharmacy and I asked for cock. And the pharmacist had no idea what I was talking about. And I said, where's the cock? I
Well, I
can't, I,
can't. I can't
I
believe the
can't,
pharmacist didn't know. What is wrong with pharmacists these days?
I know. It's a funny joke. I love that joke. Okay. Yes,
Neurologics.
NeoQ10 from Theralogics. Okay. Lost as to what to do next. I'm 45 mid-November. That's the cutoff for the clinic to use their own eggs. I started with aggressive cycle planning. I had no response. And then I had 2 mini IVF stims canceled. My third
Mm.
mini IVF with no follicle, no egg. What should I do?
That's a tough, did you say 45?
Yeah.
Yeah. I mean, unfortunately, these are scenarios. You could try to follow your own natural cycle to see if you're producing an egg and try to go for it and retrieve it. But unfortunately, realistically, a lot of the eggs, even if retrieved in that age group, are going to be chromosomally abnormal. So you may want
Right.
to talk to your doctor about, there's always options.
Right.
That's the best part about fertility in general, depending on what options we're willing to entertain.
Yeah. I
Um,
mean, I would go for creative family
yeah,
building.
right,
I mean, you can never look back and say that you didn't try your very best
right,
with what you got. But the
right,
reality is, like, most people can't get pregnant over the age of even like
right,
40, right? I mean, it's
right.
just so hard. Okay. What are reasons why eggs don't fertilize? Diane?
Well, it depends. I mean, it could be due to egg quality. It could be due
Mm-hmm.
to sperm's
Mm-hmm.
ability to penetrate the egg. And there's some
Did you
rare
just say
instances.
penetrate?
Yeah, the sperm needs to penetrate the egg. This is right after your CoQ10 joke, right?
Exactly.
Um, and sometimes there could be like, something wrong with the calcium ionophore process of the egg that doesn't allow for fertilization to happen. So.
Mm-hmm. Yep. Okay. Sounds good. Here's another question. We're going to be done here in about 1 minute. You got 1 minute for me, Diane?
I got 1 minute for
Okay.
you.
Thank you. So you guys, this is Dr. Diane Ambartsumyan from Reproductive Partners in Los Angeles. What's up in the house? Okay. Here we have 33-year-olds old, AMH 0.9, FSH 11.6. Just started my first IUI Clomid cycle, baseline 2 follicles. Doctor already talking about donor eggs. Oh my God. Oh, my original plan was to do IUI until I can schedule IVF. I mean, you can see our reactions hearing that. So, what do you think?
I mean, honestly, I'm not saying IUI will not work, but if you're starting to think family planning, depending on how many, I always say, let's plan, how many kids do we want? I
Mhm.
would, I would skip the IUI and go straight into IVF, not only for trying to hopefully get pregnant now, but potentially also bank some embryos for later use.
I
But
agree.
definitely, donor egg is not going to be my first option.
No,
So
that's not on my list.
yeah.
Not on my list.
Not at
Okay,
all. Not in the early 30s. Oh my.
exactly. Okay, two last questions. What supplements are good for men?
For men, I mainly talk about. I don't have a specific. I've thought about giving them NAD, but I know there's no data on sperm, and
There is. I found a
there is.
study. Uh-huh, there is. Yeah,
Okay.
NAD, and I even sometimes give guys HGH. There are a couple studies in
Hmm.
PubMed around that. So HGH is something that I also tell guys to take too sometimes.
Yeah, and
Yeah.
I'll always just talk to them about antioxidants, vitamins.
Mhm.
For men, one of the best things you can have them do is frequent ejaculations,
Mhm.
especially when they're going through IVF. And it sounds sometimes counterintuitive because the partner is on all these medications and they
Mhm.
don't want to have sex, so they think they're saving up. It's the worst thing you could do.
I
So
say the same thing. We're like the
yeah,
same person. I'm
I
like,
know.
you don't need to save up. And they're like, well, I read online. I'm like, you don't
No,
need to read online. Like, I'm
no,
telling you the legit truth. I'm not like lying to
yeah.
you. Yeah. Okay. Actually, I lied. Two more questions. Why do people do natural IVF cycles?
A couple of reasons. One is if they don't want to take any additional hormones and they just want to
Hmm.
go for, and the thought process is, well, perhaps nature is actually picking the best egg to drop. I just personally have found it a little bit difficult. Natural IVF, ovulation happens a lot quicker, and it's a little bit more difficult to time it appropriately. That's one reason. And two, like the case with about the 45-year-old we talked about before, if nothing else is working, maybe just kind of go naturally and follow the cycle and see what happens.
I agree. Okay, last question. I lied. What could an AMH of 7.5 and an FSH of 8.3 mean? She's labeling the FSH as high, but what does that mean to you if someone has an AMH of 7.5 and an FSH of 8.3?
It just means they have good number of eggs in their reserve.
Mm-hmm. Mm-hmm.
Um, it doesn't give me much information about quality. Age gives me the most information about quality. So, but when I look at those numbers, I don't even notice the FSH. I just
Right.
notice the AMH and go, we got some eggs to work with. So,
We do. Fertility
yeah,
indicator, high fertility.
right.
Okay, Dr. A, will you come do this again with us?
Absolutely. This is so fun.
Check your schedule next Thursday, the next Thursday, and the next Thursday.
Sounds great.
Block it. Have your people call my people and we'll have party again. So we'll
That
talk
sounds good.
offline, but I'd love to have you on again because
Yeah, absolutely.
I love
This is
talk.
fun.
It's super fun. So thank you again for Proof Test. Rule out infertility issues due to ovulation problems using Proof Kits to confirm successful ovulation. You guys can get 25% off the Proof Kit with code all caps Amy 25, like Dreamy, AIMEE 25. Thank you, Dr. A. We love you.
Thanks for having
And thank
me.
you everyone for joining us, and we'll see you hopefully next week. Okay. Bye everyone.
Bye.
Bye.